name is Jorge Cortes from MD Anderson in Houston, and I'm going to be presenting today the results of a study of a new drug called Ponatinib, and that's for the treatment of patients with chronic myeloid leukemia or with Philadelphia-positive acute lymphoblastic leukemia. Now, all of you know that we've made a lot of progress in chronic myeloid leukemia. We've had very good drugs from Imatinib and then Dasatinib and Nilotinib, but we still have a subset of patients that do not have adequate treatment. There are some patients who have already received 2 or 3 tyrosine kinase inhibitors and they still don't have a good response. And then we do have some patients that have mutations that are not sensitive to the drugs that we have available today. One of these mutations, for example, is called T315I. Ponatinib is a new drug. It's another tyrosine kinase inhibitor, and it was designed specifically to try to overcome the resistance that's generated by these mutations. One example is this T315I. What this mutation does is it has a very bulky part that prevents all of the drugs that we have available today from binding the kinase that we want to inhibit, the one that comes from the Philadelphia chromosome. So the way Ponatinib was engineered, it allows it to fit even in the presence of that bulky residue, and with that, it allows it to inhibit the kinase, the protein that causes the disease. But in addition, Ponatinib also inhibits all of the other mutations that we see commonly in the clinic. Therefore, it makes it very amenable to treat patients with any possible mutation. And in the laboratory, it also prevents the growth of resistant cell lines. So it could also have the potential to prevent the development of resistance, not only to treat resistance. So based on these properties of Ponatinib, we first did a phase 1 study, and that study was very recently published in the New England Journal of Medicine, and we're going to be presenting an update tomorrow. But that led to the development of this phase 2 study, which is a very large study with 449 patients included in all different stages of the disease and also with Philadelphia-positive acute lymphoblastic leukemia. Importantly, this is a very, very heavily treated population. As you can see here, the great majority of patients, more than 90%, had received already at least 2 tyrosine kinase inhibitors. And about half of the patients and 60% of the patients in chronic phase had received already 3 tyrosine kinase inhibitors or more. So very heavily treated population. And an important predictor of the response to a new drug in CML is how well you responded to your previous drugs. And as you can see here, only about 1/4 of the patients had responded at all to the previous therapy. So very heavily pretreated and very resistant to all prior therapies. Now the presentation, the primary endpoint here for the chronic phase is to the achievement of what we call a major cytogenetic response. That means you eliminate the Philadelphia chromosome in the majority of the cells. In the more advanced stages of the disease, of course, those are patients that are more difficult to treat and more resistant to all therapies, so we want to achieve what's called a major hematologic response. You make a good control of their counts, very similar to what Dr. Levis described for acute leukemia. So this is the overall results for all these different cohorts. And as you can see, there's a very high rate of response. 56% of the patients in the chronic phase achieved this major cytogenetic response. And then in the accelerated phase, almost 60% of patients achieved this major hematologic response. And in the blast phase, about 1/3 of the patients achieved this response. Now, my presentation today, a little later this afternoon, will focus on the chronic phase. On Tuesday, we're going to have Dr. Kantorjian present with more detail the advanced stage results. So these are the results in the chronic phase. And as you can see, we have 267 patients, the majority of them refractory and or intolerant to Nilotinib or Dasatinib. Some of them, in addition, had the mutation T315I. And as you can see, 2/3 of the patients have a cytogenetic response. We eliminate some of the Philadelphia chromosome. And this is complete, a complete response in almost half of the patients, 46%. Just to put these results in perspective, when we have Dasatinib and Nilotinib, very good drugs for patients for treatment of resistant patients. In those studies, on patients that had only failed therapy with imatinib, we get about 40% of patients with complete cytogenetic response. Here, on patients who failed already 3 tyrosine kinase inhibitors, we get 46% complete cytogenetic response. And the responses continue to improve. And we're already getting very deep molecular responses, as you can see, with about a third getting these major molecular responses. These responses are very durable. You see that 91% of these patients are predicted to maintain the response. The follow-up is still relatively short, but this is very encouraging, very sustained responses. And the responses, as I mentioned, occur regardless of the mutations. As you can see, patients that have mutations other than T315I respond very well. 57% of these patients have achieved a major cytogenetic response. And you see all the panel of mutations, all of them have responders. And even patients that have no mutations also have a very high response rate, 49%. And importantly, the drug is very well tolerated. It's an oral drug, like the other tyrosine kinases that we use. Most common side effects are skin rash or dry skin, but these are usually mild and very manageable. The one side effect that we saw that limited the dose in the phase 1 was the development of pancreatitis. Fortunately, this is not very common. The grade 3 pancreatitis is seen only in 6% of the patients. 11% have grade 3 elevation of lipase. And this is transient. We can manage that well. Actually, only one patient of all the 449 has had to come off study because of pancreatitis. So it's something that is definitely manageable. So I think these results suggest that Ponatinib have an outstanding clinical activity in patients with chronic myeloid leukemia or Philadelphia-positive ALL. These responses happen regardless of the stage of the disease, regardless of the presence or absence of mutations, and the responses are very deep and very rapid and sustained to the extent of the follow-up that we have so far with a drug that is very well tolerated. And this has triggered a number of new studies in different settings, including the frontline setting after failure of only one TKI in combination with other drugs, et cetera. So I thank you for your attention.